Yeah, I think I put it winding down. Whatever. You can do what we want to do. Whatever you want to do.
And thanks. Mine's not on.
Yeah, it is.
Hello.
It's on.
Good afternoon, everyone. Is it, everyone can hear me? In the back, everybody? Thank you for coming. This is the last day of Global Health Week, and we really appreciate all of you participating today. And I especially want to thank our residents and Dr. Reece for participating in Global Health Week. As you know, we're having it this year in collaboration with Diversity Week. There's so much overlap, right, with our goals and our mission with diversity, equity, inclusion, and global health. So first, I'd like to thank you all, and now I'd like to introduce Dr. Josephine Reece. She is going to introduce our panelists today, our residents, and Dr. Reece is the director of the Global Health Track for Internal Medicine residents, and she'll be able to tell you more about that perhaps too as the hour goes on. So thank you, Joe.
Thank you, Dr. Fisher, for having us and allowing my residents to speak each year at Global Health Week. So we thought, since this is also Diversity Week, that we would kind of touch on the diversity that we encounter in global health, as well as the inequities that we see kind of globally, as well as here in the States. So can you guys hear me? Is this better? Yeah, okay. And then how do I move? Oh, there we go. So a little bit about the Global Health Track. I started it about 10 years ago. Is when we first started it. We've had 29 graduates. We currently have 15 residents in the track. And the way our Global Health Track works is that during your intern years when you get to apply for it. And right now we allow everyone to be in the track that wants to be in the track, as long as they're in good standing with regular requirements of residency program. And then they get to travel their second and their third year, spending 1 month each time overseas at one of our international sites. Where we go, so the bolded countries are the places that we're going this year. So Guatemala, Ghana, Fiji, and Uganda. Guatemala and Ghana are places that we've been going to since I actually was a medical student back in 2008. So those are our long-standing partnerships. The other countries are also sites that we've gone to before. And every site is a little bit different in kind of what we do there. So this is a picture of the residents that were there last year in Ghana. In Ghana, we go to the Baptist Medical Center, which is a rural government hospital in the northeastern part of Ghana. We do both inpatient and outpatient care, seeing both adults and children. We're lucky enough to have some internal medicine and pediatric combined residents in our program. Guatemala is, we go to San Lucas Tolumon, which is right on Lake Atitlan. And this is a rotation where we work with volunteer community health workers. And so we go to little rural villages or fincas and set up mobile clinics. Paraguay is a site that's actually at an academic medical center in Asuncion, Paraguay, where we go to an academic center, a bit more robust than most of our sites, but they still have a lot of limited resources compared to here. And then Fiji, my resident that went to Fiji last year is no longer here. She graduated, but Fiji is similar to Guatemala in that we work with community health workers and nurses setting up mobile clinics, kind of more in the highlands of Fiji or on some of their smaller islands. So not much vacation or beach time. I've already kind of talked about the different sites, and then there's the diseases that we see usually are tropical medicine versus just kind of the common things that we would take care of as internal medicine or pediatricians, just with limited resources. But we're always working side by side, the healthcare providers. And so I thought I'd start and let my residents that are here introduce themselves and kind of answer this question of what made them interested in global health and what experiences maybe they had already had prior to entering residency. I also have a few residents that were not able to attend who have sent in audio clips or video, and that I'll share those. Hopefully they'll play. So whoever would like to start over there.
Hi, everyone. I'm Hiba. I'm a third-year resident right now in internal medicine. I went to Guatemala last year. I had a great experience. I think one of the reasons why I considered participating into Global Health Track is because I love the diversity. I like practicing with minimal healthcare resources. I also grew up in Pakistan, so it was nice taking all of my knowledge from here, from America, and going back to a place that is like underserved and try to give back. And I like different cultures, and I also enjoy traveling. So I think it was a good option for me to be able to combine both my passions for medicine and traveling together. Thank you.
All right. My name's Alyssa. I'm a fourth year med peds resident. So I feel like I have a pretty similar answer to Hiba. If you see me looking at my phone, it's because I'm pretty bad on the spot. So I have a few little notes there. But for this question, it's pretty similar in that, I actually became interested in global health early on, always interested in working with underserved populations. I feel like wherever we're training at, we definitely see a lot, but there's also a lot that we learn about that we don't get to see. And so experiencing, different diseases and whatnot in other parts of the world. Also just learning about other healthcare systems, because of course there's always, a really good sharing of knowledge there on both sides when you get to go to those places, and learning how to, practice medicine with limited resources, which I think is super applicable to all parts of the world, including, even in West Virginia here. So that was a big part of it. I had gone to India and Nepal beforehand in medical school for a month. I had done Honduras in undergrad, and I went to Ghana this past year.
I'm Tim. I'm also a third year resident, internal medicine categorical. And I like global health because, one, I have a general interest in global affairs. I spent a lot of my childhood overseas, especially in Latin America. So it's kind of a natural thing for me. But more importantly, I think it's a very great way to learn about things in an external environment. As has been said, we tend to get a pretty set patient population here. They have certain conditions, but there's other things like tuberculosis or, chikungunya you don't really see here. So being able to go overseas helps broaden your differential, improves your treatment options, and also hones your abilities as a physician, because we have lots of resources here. Guy is, his stomach hurts a little bit, so we send him to a CAT scan, or isn't even hurt and they send him to the CAT scan in the ER. Being able to do things in a resource limited environment, really, I think, hones your skills and makes you a better physician. And you can, more importantly, help out a lot of other people who definitely need it.
So we also have Dr. Melissa Roberts, one of our third year residents, who is interviewing for cardiology, I think, today, which is why she couldn't join us. So she actually came to us from Grenada in the Caribbean. And so she shared that before kind of starting her residency here in West Virginia, she had gained exposure to different healthcare systems, doing clinical rotations in her home country of Grenada, as well as in Miami, witnessing the contrast in resource availability, as well as disparities in healthcare access, sparked her interest in global health. And these experiences fostered a desire to learn about interventions that increase health equity for individuals on a larger global scale. And her goal actually is to do a cardiology fellowship and then hopefully be able to return back to Grenada and help provide care for them there. And then our final resident who couldn't join today because I have two more residents, but Rita Janat, who joined us from Pakistan, is interviewing for a rheumatology fellowship. So she sent in this audio clip. But it's not playing. So sorry, I was hoping that would work, but it doesn't seem to be working. But she had talked about before she joined us for residency in Pakistan, she worked in a mobile health unit that traveled to the different rural areas of Pakistan to provide much needed medical care as well as health screenings. And that kind of is what prompted her to want to continue to do global health in her training, and why she actually joined us here at WVU. I hope the video clips maybe will play later. If not, I'll just have to share them. I always share this, those of you that know me, when I do a global health talk, is this statement from the United Nations General Assembly that actually, they made this statement back in 1948. It's the Universal Declaration of Human Rights. And so it says that everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond his control. And I think we could all agree that currently our current health systems, whether it's at the community level, the state, country, or continent level, we're not meeting the needs of all of our people, despite this being declared in 1948. And so one of the things that we've been that they try to attain are these sustainable development goals. These 17 goals were hoping to be reached by 2030, after not reaching the Millennium Development Goals that were due by 2015. And so how do we reach these sustainable development goals where we can actually improve the health of all people? And the thing that we need to start thinking about in terms of global health is this concept of diversity and solidarity. And so this was a panel that actually was at the Women and Girls Conference in Africa that occurred in November 2020. The closing plenary was a panel by Dr. Ba, who's from Senegal, and a couple of other members. And they talked about diversity and solidarity in global health and then published this paper. And one of the quotes that they had in it is that only through diversity in many forms can we ensure solidarity and effectively address these unconscionable inequities in health. And what I really got at was representative participation. So the communities that we're going to serve, the people that we're working with that are doing the work should represent the communities where we go. And so that's why we partner with local healthcare providers. So we don't want to be a group of physicians or health providers that are coming in, doing our own thing and then leaving without actually joining with the community. And it's a kind of that proverb, nothing about us without us principle. They know what is most important to the communities. They know what the needs of their members are. And not only can they help us bridge these cultural and language barriers that we may have, but it actually just leads to more confidence in the system. If the patients that we're seeing are seeing providers that look like them, that have the same culture of them, that sound like them, they're going to be more likely to have more trust in that system. And so that's kind of why we make it a point that when we're looking for new sites, that we're building partnerships that are going to be sustainable and that we're involving the local healthcare providers. And so the next question that I wanted to ask my residents was thinking back to their rotations. And again, they did the kind of spectrum of them. We have Ghana, Guatemala, and Paraguay listed. What was your experience like, particularly your interaction with the local healthcare providers? How do you think that benefited your experiences, but also the experiences of the patients?
So in Guatemala, we basically had mobile camps. We stayed in a town called San Lucas Toliman. And over there weren't a lot of physicians. What they had was something called healthcare promoters. And there were a bunch of women who were part of different villages near the Lake Atitlan. And they were basically educated by physicians on how to do important things, like how to encourage patients, especially females when it comes to breastfeeding and stuff, because malnourishment is one of the problems that the country faces a lot. So when I interacted with the healthcare promoters, they would frequently ask me basic questions. Like one of the questions that I encountered was like mainly in regards to breastfeeding, about whether breast milk is something that could be shared, which is something that they didn't know was a thing. Like what would happen if one of their women who's a mother now cannot produce milk. So I was able to give them presentations, teach them, educate them based on that. Other than that, I think just basic healthcare, hygiene, what's important to take care of an infant, nutrition. I think those are things that they did lack, and I did try to educate them. They did all come to the main hospital in San Lucas, and they sat there, they got their lectures over there, and I was also able to give them presentations. Yeah.
So I went to Ghana, and being one of the med peds folks there, I did spend quite a bit of time on the peds inpatient side, although we still rotated, through inpatient medicine, peds, and then we also helped out with the outpatient clinic. So I feel like we got a pretty wide breadth of everything there. And it was often very busy. But I thought it was really neat because we really did work alongside local providers. So it wasn't us just going in there, bringing our way of doing things. It was, we'd walk in, we'd see the local pediatrician there, we'd sit down beside him and say, okay, how can we kind of divide and conquer here? And then, they're sitting right there. So you can ask them questions if you have questions about how they would typically, manage things there. And it was really collaborative in that way. And I do think, for them, they work a lot. And so I think if anything, that's something that we were able to help bring, was kind of decreasing that workload for them, even for that short time that we were there. And then we had a lot of really neat conversations about, oh, how would you manage this back home? And how do you manage this? And really getting a better understanding of what was important to people there. And there are a lot of cultural things that we learned about too. For example, this is just a little tidbit, but I thought one of the coolest things about being in Ghana was like breastfeeding. Like it was just so normal, and like no one would even, look at anybody a certain way. But there are a lot of other cultural things too. You know, there might be multiple wives in a household. So learning how to talk about things in a culturally respectful way, particularly when talking about like STIs and stuff like that. And what was the other part of the question? Yeah, so and then we would have nurses who would help us translate. And so recognizing that they're providing us that service, you know, they're walking around with us and being very patient and helping us communicate, which of course adds time. And but at the same time, it would still be like really beneficial, I think, from both aspects, because they would say, oh, you know, I learned this when you were talking to them about this. And so it was that, again, shared knowledge. And then I can't remember if this was part of the other question or not, but one other thing I wanted to bring up that I thought was really cool is diversity wise. You know, even though we were within one community, there would be so many different dialects spoken, you know, so many different types of people from different tribes. And so sometimes, you know, the nurse would even have to shout out to the whole room to say, hey, is there anybody here who can speak this dialect? And so it was just a very like collaborative thing overall that was really neat to see.
Yeah, I'll amplify that a little bit too, because that was similar to my experience in Paraguay. I speak a fair bit of Spanish, but I tell you, when you go down there and you're dealing with patients, you know, there's some dialects and stuff. I felt like I spoke no Spanish at all effectively. You know, I was, so I depended very, very heavily on the local care team. In addition to that, of course, there's a lot of nuances in every culture, something that you would take for granted here. For example, you know, someone, you know, ideas about like people from West Virginia or people from California or Hawaii. You're not familiar with that when you go to another country. So working closely together with the healthcare team to be, you know, sensitive to cultural differences within the country and within different cultures in a country is very important. So it's really important to have like a heart of learning. You're not going there to kind of teach them how to do stuff. You're going there to learn how they do stuff and to help them, you know, almost like a medical student. So I think that humility is really important, and it really reinforced that, because again, I thought, oh, I've been to Latin America plenty of times. You know, I've even been to Paraguay before, but going there was really quite an experience, because basically I was in learning mode all the time. Even at the end of the thing, it was all learning. And again, it was also a great way to appreciate, because it was a national medical center, just the differences across this one country that most people don't even think of. You know, people kind of forget it's there. But it has quite a few differences in it, and it's quite important to understand that and realize it and be respectful of it.
Thank you. And I think Melissa shared, so she was in Ghana, like I said before, had a fantastic learning experience during my global health rotation in the Lergu. We worked alongside the local Ghanaian doctors, nurses, were very welcoming and helped orient us to the facilities and workflow for ordering labs, obtaining imaging and performing procedures. Moreover, they provided key assistance with translation, and without a doubt, the local staff played an instrumental role in helping us deliver patient-centered and culturally sensitive medical care. As Alyssa had mentioned, there are several different languages that's spoken in Ghana. And so even up in the Northeast region, we also are on the border of like Burkina Faso and Togo. And so we had some patients that had come across the border from those countries and would speak French. And then we were really struggling to find my sister or someone else who could help us translate. The next slide I'm hoping will play, it may not, it's a video from one of our other residents, Giles Knoll, who's graduating from Med Peds this year, and he was talking about his experience in Ghana. So we'll see. Nope, not gonna play.
Be a master volume.
Mm.
Free the Giles.
Frustrating, right? Can you help with share?
I know. And this is why technology is not always a good thing. Yeah. Yeah. That's fun.
Hey guys, my name's Giles. I'm one of the Med Peds residents. It's nice to meet you guys.
We can reverse it.
I can go for it.
Yeah.
I'm sorry.
Give you a break.
I know, I have to see Dr.
Hey guys, my name's Giles. I'm with Med Peds.
I believe in you guys.
Hey guys, my name's Giles. I'm
Dr. Reece,
Peds
I can
resident.
into the microphone.
It's nice to meet you.
Send me the slideshow.
I'm sorry because of fellowship stuff. I just couldn't make it in.
Thank you, Leah. That's such a
Hey guys, my name's Giles. I'm one of the Med Peds residents. It's nice to meet you guys. I'm sorry because of fellowship stuff. I just couldn't make it in. I'll tell you a little bit about my experience. I'll try to make it brief. So my passion for global health really started with refugee care through volunteering activities before medical school. And then I spent about 6 weeks in Guatemala doing mobile clinics before medical school and really fell in love with this population. In residency, I got to go to Ghana this last February, and we went out to a rural hospital and were able to give these Ghanaian physicians a break. I mean, they work 24/7. Some of them still came in a few days a week even while we were there, but just giving them the opportunity to recharge so they can give the best care they can was amazing. And getting to work with them and work with the nurses was incredible. I mean, there were a ton of opportunities to learn from them in terms of pathology I don't see very often. And learning about how to utilize the limited resources we have there and how to work around the fact that our patients there, they pay cash before they leave. And so having to be very cognizant of what I order and how I spend my patients' money essentially was a really awesome experience. And then I had one experience where we had a patient that had a progressive CNS tumor. She was a 9-year-old little girl, and I mean, she had even had a biopsy-proven result. I think it was an astrocytoma, but it was causing compression of the fourth ventricle. She had bad hydrocephalus, was cachectic, and it was just clear that it was time to have a conversation with the family. And the nurses, the physicians, they were able to talk me through culturally how to work through this process of talking about a dying child with the family and how to give them resources to give the best version of home hospice possible. We were able to work through that with the family, with their help, and it was really humbling to have to ask even questions like, am I the right person to do this? Should this be a native speaker that has this conversation? How does this get communicated? And we were able to do it in a way that I think was as beautiful as it could be, and we were able to send them home with some medications and instructions to help the process along and in terms of comfort and give this girl the best chance that we could imagine to have a dignified passing. And that was just amazing and couldn't have been possible without people there that know the culture and know the language and were able to help me through that. So I'm so thankful for the people there and getting to learn from them. And then in terms of healthcare inequities, we had a ton of kids that had what looked a lot like measles. We couldn't test for it, can't 100% prove it, but we talked to the families, and it turns out that all of the vaccination out there is done through the public health department, and all of those resources were pulled because of the COVID pandemic. And so these kids were the first set of kids in a long time that hadn't had any access to vaccinations, and the families were pretty disappointed by it, but the people just didn't show up. And now we're potentially seeing a measles outbreak because of it. And I mean, I see the same things here in West Virginia because we have folks. I had a gentleman who was evicted recently and was living out of his car and trying to ration his insulin and ended up in DKA and just didn't know where his resources were to try to improve that and not have to be in that situation. And I've had countless experiences like that here, and it's really heartbreaking. And so I think the same things that we're applying globally in terms of improving access, improving knowledge, and helping patients be able to take care of themselves better and achieve better health equity essentially are the same things we should be doing in our rural communities here. And so that's been really, really convicting in a lot of ways.
Hopefully you guys could hear what he was saying. He was telling the story of a young girl who had been diagnosed with a progressive cancer. And how do you have that conversation is hard enough to have here in the States with pediatric patients or even our adult patients. And that process of choosing how to die with dignity and how to have that passing be comfortable, but also acceptable in that culture. And so without being partnered with the local healthcare providers, that would not have been something that we would have been able to achieve. And then he kind of got into the health inequities. There's a measles outbreak when we were there due to vaccines being kind of stopped with the COVID pandemic. The public health department had kind of shifted towards COVID, and we're still trying to catch up after getting back to work after the COVID was over, but not really. And then, so I wanted to move on to health inequities and kind of thinking about the differences that we see globally, but also here, even in West Virginia. So health inequity, the WHO, the World Health Organization, the definition they give it is a difference in health status or in the distribution of health resources between different population groups that arises from social conditions in which people are born, grow, live, work, and age. And so it is an unjust and unfair result of basically social or political structures. It's not based on a choice of the individual. And this can lead to health inequalities such as differences in life expectancy and infant mortality, under 5 mortality. If we think about life expectancy for someone that is born in West Africa and Sierra Leone, their life expectancy is 50 years old compared to someone in Japan where it's 84. Even if you look within the United States, West Virginia has the second lowest life expectancy. The average right now from, I think, 2020 statistics, the US life expectancy is 77 years old, and West Virginia it's 72.8. So just being born in West Virginia, that's what your life expectancy is going to start out with. If we think about under 5 mortality, if you were born in sub-Saharan Africa, you were 14 times more likely to die by the age of 5 compared to anywhere else in the world. And we know that poverty and living in a rural location puts you even more at risk of dying before your 5th birthday. And for those of you that have been paying attention here in the States, last week, I think it was the American Community Survey came out about poverty, and West Virginia has the second highest rate of poverty, both in adults and in children. We have the highest rate of poverty in children under 5. 30% of our children under 5 are living in poverty. And then we talk about access to care. And so if we think about the health workforce, now these numbers I'm going to share are a little bit old, but I think the trend is probably still the same. If you're looking at the Americas, so that includes North America, South America, Central America, the Caribbean, it accounts for 14% of the world's population, 10% of the world's disease burden, 37% of the global health workforce, and spends about 50% of the world's finances, resources for health. Compared to Sub-Saharan Africa, just as much of the world population, if not more now, 24% of the world's disease burden, so a higher percentage of that burden of disease, only 3% of the global health workforce, and they spend less than 1% of the world's financial resources for health. And so you're already going to be set back just by the location of where you're born. If we look here at West Virginia, 51 of our 55 counties have been designated as fully or partly medically underserved area or medically underserved population. And the way you kind of get this designation is they take into account number of primary care providers per 1,000 population, the infant mortality rate, the number of people living over the age of 65, and then the number of people living below the 100% federal poverty rate. And so almost all of our counties are considered medically underserved. So going back to my residents here, what are some examples of health inequities you've experienced either as a resident physician or even personally before you became a physician? And that can be globally or it can be here in West Virginia.
Okay, well, I'll give Hibba a break and go first. So I live in Boone County, which is most famous for a fellow named Jesco White and the rest of his family. It's one of the poorer counties in the state, quite a lot of health inequity. A lot of folks struggle to get even just kind of basic meds. If it's not on the Walmart $5 list, which a lot of people need meds that aren't, especially a lot of coal mining down there, a lot of black lung, a lot of people who smoke in addition to working in the mines. So a lot of very expensive pulmonary meds that aren't really well covered or covered at all. It's pretty, even within this state, it's pretty interesting to see how there's a divide between somewhere like Charleston or Morgantown, where you have very wealthy people who have access to a very high level of care, and somewhere out there where people are still on warfarin for AFib, and then my travels have only amplified this. Again, many countries, the US is, just one well-developed country. Other places, like the UAE or something, also have very high degrees of health service. But there are many places in the world where there, are no health facilities whatsoever. Even in Australia, which is a fairly developed country, they don't have any health services at all for most of the interior. They have one town that has about 1,000 kilometers in every direction of no significant settlements or hospitals. They have to fly people around. And then other places like inner Brazil, even less. So yeah, there's quite a few iniquities brought on by not just, geography, but also just by how things are run and the focus we put on things. It's much more profitable to treat somebody for high cholesterol than it is to create, say, a vaccine for a neglected tropical disease. So these systemic issues are definitely present everywhere.
I think he did a great job. I would also echo a lot of that. I wanted to circle back to like what Giles brought up as an example, because Giles and I worked really closely in the PEDS unit in Ghana, and we did see those cases of measles. And I think one of the most shocking things to me was seeing a case of tetanus. And then having to really think about our resources there, like he mentioned, in terms of cost. This family can't afford the treatment for tetanus, and because they didn't have access to the vaccinations, now they're kind of stuck and we're just treating symptoms. And I feel like, that really carries over even here. We still have a lot of transportation issues that we saw there with patients. Do we send them home earlier than we feel comfortable with, because for them, they can't coordinate transport home? Is it safe transport? They can't afford another day in the hospital, and I feel like we still see very similar things here where, people worry about getting home to their kids. They can afford childcare. So a lot of those socioeconomic factors play a big role. And thankfully here, we have some more resources. We have care managers and social workers who can help facilitate some things, but not always. And telemedicine shows some promise for all the people here in the US who are in the more remote areas, but that still isn't an answer to everything. We don't have like the specialists everywhere in the country that we might have in some places. And so, there's definitely inequities there. There might not even be a pediatrician in some communities, for example. And so I think it's easy to assume when we see our patients, non-adherence, non-compliance, but I think it's, something that I really take from these experiences is really having those conversations with patients and seeing their point of view and seeing how we can help them, because I think that's something that we oftentimes miss, whether it be for burnout or whatever it is, but really making those human connections and trying to figure out, how we can help even with our own communities.
I think something for me that was a bit shocking when I moved here, because I grew up in Pakistan, was how easily it is to give pain meds over here. In Pakistan, if someone has a femur fracture, we're not going to give them morphine. It's not available. We're not going to give them oxys. It's not available. We're going to probably just give them Tylenol, or we'll tell them to like suck it up at that point. So over here, I feel like there's something that when I deal with people over here, it's kind of hard for me to not think of that. Because over here, we sometimes see so many people who are drug seekers, sometimes people who are getting pain meds every 4 hours, and they like, give us more, give us more. And I kind of start thinking about back home where these people, other than if they have like metastatic cancer with bone meds, that's when we would offer them an opioid, maybe even just one time. So I think that's something that was very surprising for me, how judiciously we give pain meds over here and how available it is. And then I think from my Guatemala experience, we didn't have a hospital. We were just doing mobile camps, and we didn't have resources. One thing we did have was finger sticks. So diabetes is very prevalent over there. So I have a patient, I do a finger stick, the glucose was like 600, 700, and the patient was just sitting there in front of me. And I didn't know what to do because insulin is not something I can give them. At most, I could give them like a 30-day worth of metformin, which I had with me. But I think that's something that made me realize how lucky people are over here who get treated. Their insulin is widely available, medicines are widely available, pain meds are there at the beck and call of the patient. So I think that's something that was really different for me.
One other thing I want to add real quick too, I was just thinking about something I experienced recently is, people even here who speak different languages. I feel like, there's system factors. We only have a certain amount of time for appointments, or when you're rounding and you realize someone speaks a different language and, oh, that'll take a lot more time, to get a translator and stuff. I feel like that definitely leads to inequities too, because they might not get the same experience with you as somebody who speaks your language. And there are a lot of factors that weigh into that. And that's something that we see here.
All right, I just have one more old people story time. When I was a child, I lived in Honduras, and I was a small child. And I was fortunate enough to be born in Virginia and come from the United States, where I had all kinds of vaccinations and treatments, et cetera. When I got sick, they flew in medicine through the embassy. There were a bunch of kids who played outside in Tegucigalpa, and there was actually a bad run of measles through there. And a lot of those kids died because they didn't have vaccinations. They couldn't really even get like hydration or even basic medicines. It just wasn't available to them. And that really left a mark on me, because I remember seeing these kids play and then they weren't. And I asked what happened. My dad told me that they died. So that fence between our house and their house was the difference between life and death. And that really has stayed with me.
Hi everyone, my name is Ridaul Janat and I'm a third year IM resident. I moved from Pakistan 2 years ago, right before my residency. Back home in Pakistan, I was part of a mobile health unit for about 13 months, where we would travel to the rural areas of Punjab and take medications with us and do some basic lab work in the villages and provide basic healthcare services to them. Having that experience and then moving to Morgantown and seeing this wonderful global health community, I was very excited about it, and I knew I had to be a part of it right away.
Just for the sake of time, I'm going to skip over Melissa's response, but it basically had to do with kind of lack of specialty care that we see even in parts of West Virginia, where a lot of our patients drive several hours to see specialists. I just want to touch briefly, kind of like, how do we fix these inequities as one institution with one global health track that takes residents once a year? I'm not going to be able to solve all these inequities, and we need to be mindful that we're not being what they call helicopters, parachutes, or parasites, where we're dropping in, doing a little bit of work and then leaving. And not actually building something that's more sustainable, because all that leads to is kind of that continued power imbalance between high income countries and low income countries. And so that's why we want to make sure that we actually are kind of building some partnerships. And these partnerships need to be broad. They shouldn't just be with one institution and one site, because it's going to be very hard for one institution to be able to continuously provide someone or provide assistance and funding year round. And so a lot of our sites where we go, there are other institutions that are also going. And so we try to match up our schedules so that it's not one team coming in once a year and then they're not seeing anyone else. And so hopefully we can have some type of schedule where there's a team coming in every 3 months or every 4 months, and that we're not restarting everything over each time. We can kind of coordinate. We need to build capacity. And so we try and do that ourselves through education, providing medications when we go, and actually purchasing those medications within the country we're in to kind of build back and give back to the economy. One of the things that we've been able to do in Ghana, a big issue that they were having was chronic hepatitis B. So they were contracting hepatitis B at birth. So then by the time they were age 20 or in their 30s, so working age, they now had chronic liver disease, cirrhosis, or hepatocellular carcinoma. So they were losing a larger portion of their workforce. And so we kind of approached this 2 ways with them. One was we helped the local healthcare providers convince the hospital administrators to start giving the first hepatitis B vaccine in the hospital before the patient left. And then number 2, we worked with other kind of partners up in Massachusetts and some other parts of the United States to kind of help develop a treatment algorithm based on the WHO's treatment algorithm for hepatitis B in resource limited settings, where we can make an easy to follow guideline for the providers there, because most of the providers that see these patients in clinic are medical assistants, or even nurses, and not necessarily a physician. And so something they could easily follow, but we also provide the tenofovir or the medication for them, so they're not having stockouts, and they can hopefully reduce the burden of hepatitis B. In terms of sustainability, we actually had almost gotten to this point in Guatemala where, you know, we've worked with these community health workers and health promoters for years and training them on how to screen for chronic medical diseases and how to treat it, to the point that we almost got to the point where they thought maybe we didn't need to come in person anymore. Maybe we could kind of help with supplies, with medications, and then develop maybe a telemed clinic where for difficult cases that they were having trouble managing or things that they didn't know, sort of how our neurology folks do their neurostroke work in Guatemala. Maybe we could have something scheduled like that because Guatemala is the same time zone. It would be easy to do. Unfortunately, when COVID happened, things kind of got set back. So I anticipate though, within the next couple of years that we may be able to move to, we don't need to be boots in the ground in Guatemala anymore. Maybe we can do more telemed or more like the ECHO project that we do here at the university, where we talk about Hep C treatment or psychiatric diseases or diabetes management with providers throughout the state who can just log on and join and learn from case presentations. And then really the key would be bidirectional learning. I'm going to harp on this with anyone I talk to. I don't have the political will to be able to make that happen, but I think we should really allow the opportunities for medical trainees, whether they're residents or students, or even if they've finished their training, but they still just want to learn more, be able to come over here and observe and do a rotation to be able to take back to their country. And so I think we have maybe a couple more minutes. If you guys could just answer how has your global health experience impacted your practice here in West Virginia, as well as your plans for the future?
All right, I can give you another break, Hiba.
We got like 3 minutes.
Yep. Very quickly, impacted me a lot, taught me, how fortunate we are, taught me how to practice better with source limited settings. And more importantly, taught me a lot of humility and gratitude, I think, which really helps a lot.
Oh man, I was going to use the word humility.
That's why I went.
Yeah, I think the experiences really humbled me and helped me get back to like the bare bones of medicine. For example, physical exam skills that, here we might not utilize as much as we do there. And just to put in everyone's heads as a perspective, like there's no up to date. So I think that was one of the biggest challenges is like, you can't look things up. So a lot of times, it is just using like your gestalt or, your real clinical judgment. Did this girl perforate her bowels? Like, I don't know. She's pretty tough, but like, there's a good chance that actually happened once. And surely enough, she had perfed. So, really holding on to those skills. And then also just, what was the other thing I put down? Oh, how I approach shared decision making. So making sure that, you're really having discussions with patients, even in places like that, don't tell them to do something. For example, we gave somebody albumin that ended up costing thousands of dollars that like that they couldn't afford. And if we would have had more of a conversation, we could have probably found an alternative. And so I think, shared decision making is something that we really have to keep in mind with all of our patients too.
I think Giles and Tim and Alyssa pretty much summed up what the month was for like me. I think in the future, I've applied for oncology fellowship. So I think I do aspire to maybe go back to these developing nations and teach them. With all of the latest advancements, like I can vouch that America is 50, 60 years ahead in medicine compared to other countries like Pakistan for sure. It's like 100 years ahead in all the research that's going on. So I think that is one of my future aspirations, to learn oncology and maybe go back to like cancer institutes. Like there's a very famous cancer institute back in Lahore called Shaukat Khanum. So I would like to maybe like educate the physicians over there about what the latest advancements are. So I think that's one of my future goals.
Thank you guys very much. And we did not make the patient pay that amount. Just wanted to clarify that. But I think they could take a few more questions or we can move it outside. I don't know if there's a class after this or not. Okay. If anyone has any questions for the residents or for myself. So someone is recommending I look into capacity building grants through USAID, and I've made a note of that. I'm just going to find a grant writer as well. And then have you considered incorporating public health students on this trip, such as MPH students? I have not before. No one has actually approached us to ask, but I think it's something that we could definitely use and would be welcome to have. We would just have to, we're always mindful when we go on these trips is how big of a team do we take? Because they're hosting us. You don't want to be burdened on kind of the living situation and the transportation they need to provide, which is why sometimes we split. So we're going to Ghana twice this year. We're going in November and in February to split our team up. But that's something that we definitely would welcome an MPH student. I think that they'd be beneficial at any of our sites, actually, because public health plays such an important part in these communities. I've been told we have a class waiting outside, so thank you guys for attending. Again, feel free to ask more questions.
Thank you, everyone, for attending Global Health Week. Thanks, Dr. Reese, for having her residents, and the residents were wonderful. We're so proud of you, and thanks for all you're doing, everyone. Have a great weekend. Thank you. That was wonderful.